Hi, my name is Brenda Hooker, and my presentation PDSA is going to be on the fall prevention in a medical surgical unit. So let's talk about the issue. According to the Joint Commission, falls are a widespread patient safety problem. Not only elderly and frail patients, but also any patient of any age or physical ability can be at risk for a fall due to changes in physiological states, medical condition change, medications, surgery, procedures, or diagnostic testing. This can leave them confused or even weakened. According to the Joint Commission, the latest statistics on falls say that every year in the United States, hundreds of thousands of patients fall in the hospitals, with 30 to 50% resulting in injury. Injured patients require additional treatment and sometimes prolonged hospital stays. The average cost for a fall with injury is about $14,000. This is because there are protocols that have to be followed when a patient falls. The MD has to be notified, x-rays have to be taken, and then patients have to be monitored for 48 hours after. Falls with serious injury are consistently among the top 10 sentinel events reported to the Joint Commission, which has 465 reports of falls with injury since 2009, with the majority of these falls occurring in hospitals. And approximately 63% of these falls resulted in death, while the remaining patients sustained injuries. Quality variance. According to the Joint Commission, 0 falls is an achievable goal. 2 recent studies demonstrate how a proactive approach can lead to a significant reduction in patient falls. Study 1 dealt with a pilot called TIPS, which stands for Tailoring Interventions for Patient Safety. This is a 3-step process that step number 1 says identify risk factors. Step number 2, developing a tailored or personalized plan to decrease the risk. And step number 3, consistently carrying out the plan. The study found that using the TIPS pilots reduced the mean fall rate from 3.28 to 2.80 falls per 1,000 patient days. Study number 2 evaluates the use of sensor technology to detect fall risk. This study found that by using sensors, they reduced the falls by 54.1% from April 2015 to January 2016. Quality variance continue. At the hospital that I work at, these were the following numbers that were reported for falls. In 2007, from August 1st to December 31st, day shift reported 15, evening shift reported 10, and night shift reported 8. And after my charge nurse and I talked to our floor manager, and we implemented the suggestions that I came up with, from February 1st to February 22nd, the falls are as follows. Day reported 3, evening reported 0, and night shift reported 1 fall. So I know it's too early to tell, but the word that I received from the manager seems to be that kind of working and being proactive about it is actually more beneficial, and it has helped out a lot. We already have protocols in place, but it seems like we needed more people to kind of like follow the protocols and kind of like having champions, which I'll go on detail later. It has helped the unit and also kind of like rally together and act as a team. So I'll go over that in a few slides over. So this is the root cause analysis that I came up with. I kind of divided it into 3 categories just to keep it easier and more specific. The first category would be patient factors. Obviously, this will be old age, presence of multiple comorbidities, occasional dizziness, and noted recently just change in condition in general. Medical team factors would be like heavy workload resulting in unsafe patient-staff ratio insufficient support and assistance among the treatment teams to allow staff to mutually take care of each other's patients. This had to do with sometimes people not reacting and just letting either nurses or CNAs just react to the call lights rather than like whoever was available or free answering the call light. The last category would be training and education. And this had to do with the inadequate use of bed alarms, failing to use the full precautions that we had, inadequate health education training related to the prevention of falls within the hospital, poor communication. Sometimes medical personnel did not proactively ask patients about their symptoms, and patients were not educated adequately at the time of admission on what to report. This is the scope of the problem. The stakeholders, patients and family members, nursing managers, MDs, physical and occupational therapists, social workers, charge nurses, staff nurses, patient care assistants, pharmacies, basically everyone in the hospital. Everyone is involved. I think patient safety should be a priority for everyone, not just for nurses and CNAs. And it seems like sometimes that is the case where safety falls mainly on nurse and then CNA and then everybody else is off the hook. And I think the culture in my unit needs to change, and I think it will change with time, where it's more of a team collaboration, and I think that will be beneficial in the future. Solution. So these are some of the steps that my charge nurse and I worked on to reduce some of the falls. The first one would be assess fall risk at the time of admission and reassess if patient's condition changed. Create a list of fall risk medications and review patient's medications. We actually created a list of all the fall risk medications because studies shows that knowing the risk factors associated with falls is beneficial. So we posted a list just so that the nurses could be aware of what kind of risk medications we had. We also created a schedule for hourly rounding, but this schedule included not just the staff nurses, but everyone, charge nurses, PCS, and sometimes MDs, because in the past it just fallen to the nurses or the PCS to answer the call light. And now it's like everyone that is available, if you're not doing anything, we gotta respond. And we have involved our doctors in this, and it has been actually working out really well. Study shows that a decrease in 46% in all fall reductions when hospitals implemented hourly rounding. We also created champion programs to educate staff on proper use of bed alarms and fall signs. We actually have fall kits that we ordered, but they weren't being used. We have yellow socks, yellow signs, yellow wristbands, and they were not being used. We already had a sitter available for confused patients, but we actually were monitoring more, about who really needed a sitter and who didn't really need a sitter. We also prioritized patients' room placement based on fall scores. High fall scores should be at the nurses' stations. We implemented a universal fall risk precaution and made sure that the staff were adhering to it. And also a champion program was created for this so that they could check if they were following protocol. Statistics shows that inpatients falls decrease when hospitals implement a fall risk protocol. So this is what we did, and it seemed like it has been working well, and people have been receptive. It seems to me that when we come from a team approach, people feel more receptive to changes. So this is how we implemented the changes. 4 champions were assigned tasks to implement the changes. 2 champions were assigned of making sure staff was appropriately assessing and reassessing fall risk at the time of admission and if the patient condition changed. 2 other champions were in charge of making sure staff were educated on the use of bed alarms, sensors, and the correct placement of fall precaution signs, and then indications such as the armrest, yellow socks, and the signs. The floor manager, in conjunction with the pharmacist, created a list of the medications that had the highest risk of falls, and then they placed that list around the unit. Charge nurses were in charge of creating a daily schedule per shift to be able to perform hourly rounding. And sitter were the charge nurse was making sure that the sitters were available for patients that needed due to altered mental status. Analysis. Factors that will help us determine if the implementations are successful obviously will be a decrease in patient falls and injuries. But in case a fall should happen, we should include the following information on the event report. That way we'll get more information, and then we can work on a way to avoid this, such as medical diagnosis, age, gender, and service, circumstances surrounding the fall, like what happened. Was the patient ambulating? Was he going to the bathroom? Did he get up from bed? Whatever happens, right? Also the risk factors, if there were prior falls, medications, just a baseline of the leg strength. Also, we'll include the manager, determine if the staff was complying with the fall, which this is important because it's not about blaming people, but it's just about changing. And at the hospital that I work at, they're trying to do that. They're trying to avoid blame, and they're just trying to just change the culture. We're also gonna record a monthly count, and just to keep track of the progress. So the next steps. My organization will continue to assess fall risk at the time of admission and reassess if patient conditions changes. Also, the fall risk medications list will continue to be posted. People have found that to be really helpful. The manager and charge nurse will continue to implement the schedule hourly rounding. People also have that found that really helpful because, like I said before, they created a team atmosphere, and people seem to respond in a positive manner to that. The unit champions will help implementing the universal fall precautions and make sure staff adhere to the guidelines. One more thing that we talk about, but I didn't put it on the slide, is because the manager and the charge nurse were coming up with incentives for the staff as far as having fall reductions. But I wasn't going to be involved with that since I was part of the staff. They didn't want me to know exactly what the incentives were. So they were going to come up with incentives and let us know like what would be a good thing for us to get rewarded on. So this is my reference page. I want to thank you for taking the time to listening to my presentation. I found it to be really enjoyable to work, and I think I've learned a lot, not only about how to keep my patients safe, but also about leadership. And in the past, I haven't had the opportunity to create something like this. And then just having my co-workers and my charge nurse and my manager respond to my ideas just felt like it made me feel really useful. Thank you for listening, and I hope you enjoy the presentation.